Ladies and gentlemen, if you will, please come in and have a seat and close the back door, and we're going to go ahead and start with our committee meeting this afternoon, our joint House and Senate committee meeting. I'm Representative Butch Parrish, and I chair the House side on there with my colleague, Senator Burke over here, and this will be a joint hearing. And today we're going to have the opportunity for those folks who want to be heard to come in and talk to us about some issues that are of interest to them. And we've got several that have signed up, and just as a little housekeeping, we'd like to ask those who are going to be talking to try to hold it to no more than 5 minutes so that everybody can have an opportunity to be heard, and there might be some questions from those on the committee or whatever. So we're glad you're here. We're glad you're having the interest, and of course in the morning at 8 o'clock we'll begin with the departments giving us their testimony about the budget at 8 o'clock here in this room. So Senator, we'll turn it over to you and let you answer more.
Good afternoon. I want to thank Chairman Parrish for inviting me to participate in this August hearing and with this August body. I want to thank a couple of senators that are spending their Wednesday afternoon that they could be sitting in the sun chilling for their participation as well. Let me start. Looking at the sign-up list, Pat Cota from the OBGYN Society. Yep, Pat's lined up and ready to go.
Good afternoon. I'm Pat Cota with the OBGYN Society, speaking on behalf of the OBGYNs this afternoon. I'm distributing some maps that will help give you a little background on obstetrical access in the state of Georgia. The blue map is the first one I'd like to discuss with you, and this is a map of the closed obstetrical units in the state of Georgia. Does not mean that the hospital's closed. It just means that the hospital has closed the labor and delivery unit. As of today, there are 31 closures of labor and delivery units. So out of approximately the 180 hospitals we have in the state, about 75 of them have labor and delivery units left in Georgia to cover the 159 counties that we have. This is important because OBs can't work without a hospital obstetrical unit to deliver their babies. An OB must practice and live in close proximity to the OB unit because babies, as you know, come 24/7, and he or she must be able to respond quickly to deliveries and the obstetrical emergencies that happen, meaning that they can't live and work 40 minutes away from their hospital base. Most hospitals require that they respond to cases in a certain number of minutes. This brings us to the second map, which is the green map. This map was completed in 2011. At that time, the white-colored counties, and Metro Atlanta showed sufficient OB services. The varying levels of green that you see showed deficits, and there were 40 counties in 2011 that had no obstetrical services at all. That means no family physician doing OB, no OB, and no midwife. Now on that green map, we've overlaid red arrows showing the latest closures of labor and delivery units. And note that those labor and delivery units are closing at more than 2 per year, at more than 2 every 12 months. Also, the key and important thing to note on this map is that those red arrows are going into counties that are colored white, which means in 2011 they had obstetrical services. But in many cases, when we redo this map, which we hope to be able to do this year, we're probably going to find that the red arrows are now going into counties that are going to be turning green because the OBs would have had to relocate when the labor and delivery units closed. This shows how fast OB services are drying up and that our real problem lies in rural Georgia, where some OBs are now seeing patients from 8 or 9 different counties. Which brings us to the next point. Research on Georgia birth show that women who commute more than 45 minutes to their delivery facility are 1.5 times more likely to deliver a preterm high-risk infant than women who drive less than 15 minutes. We know from our research that from 1999 to 2009, a quarter of the women in Georgia drove more than 45 minutes for services. We know it's worsening now due to what you're seeing on the maps. An NICU baby can cost up to $5,000 a day. When 60% of our births are Medicaid, it's very costly for the state immediately after birth and long term if that child never gains their full potential due to a poor birth. We very much appreciate the dollars in the medical education budget to increase scholarships and medical education funding. This will help keep aspiring young doctors in Georgia. But when they open practice in rural Georgia, they have to be paid enough to keep their doors open so that they can stay. We understand that there are budget constraints and that asking for an increase in all fees would be impossible. Therefore, we ask that you consider increasing our rate on a select group of delivery codes that would be most helpful in maintaining access to OB care in rural Georgia. This would involve raising the fees to Medicaid parity, which is the standard fee that's recommended by the Medicare system. The OB community has been waiting patiently for over 14 years for adequate reimbursement to remain in practice. As you can see from the maps, OB care is now reaching a critical stage, and we would very much appreciate your assistance this year with at least a few key payment codes. Thank you, and I'd be more than glad to take questions.
Thank you, Pat.
Thank you. I do have a question. It had to do with high-risk pregnancies.
Yes.
Can you tell me the percentage that have increased? I know it's definitely related to reimbursements and people having to travel and things like that, but we've seen in our district an increase in the high-risk pregnancies.
Yes, I can tell you that we now rank 45th in high risk or in low birth weight delivery, so we're heading more toward the bottom of the barrel every year as far as our rates.
Okay, thank you.
Certainly.
Years and years ago, we worked to include pregnant women into the Medicaid. And that the reasoning for that was not only them, but the baby, the sake of the baby. At that time, a normal delivery, this is going to let you know how old I am now, was $4,000, but the complicated births were $14,000. So it was pretty easy to show the state that we were actually saving money by, you know, including pregnant women and having prenatal care so they'd have healthy babies. My question to you is, what are the costs now, estimated costs, for a healthy delivery versus a baby at risk or a sick baby?
I think Dr. Sexton is here, and he can probably address the pediatric side of that question. On the obstetrical side, we are paid on a global fee, which means that we are paid at the end of the delivery $1,300, regardless of the care provided during the pregnancy. So we may see that woman 9 times, or we may see her 29 times, but we give the entire care for 9 months before we are paid. And that's how it works on the obstetrical side. Does that answer your question?
$1,300?
Yes.
Okay. Thank you.
Tom, go ahead. You have a question? I'm trying to get your mic on here.
That mic didn't work yesterday. You may have to get the one next to it, if we can get there.
No, we can't get it to turn on. Just speak loud enough and hear you.
Dr. Kidd, I just pose a question. I'm looking at your both of these maps, and the one the green,
Yes.
or the one that's mostly green, it looks like to me. The at-risk counties being, there's a lot of them.
Just turn it off and then turn it back on. See, that usually works.
But near the border.
Yes.
And as I understand the rules that the state has right now, the rule is you can go out of
Good
state,
idea.
up to 25 miles over into another state, have birth done
That's a very interesting question. First of all, I'm just the executive director, so I'm not a physician. That's an interesting question. When we've done studies of the state and where high-risk births went, what we found is that the at-risk births, when they're transferred and when they go to hospitals, they try to take the fastest, quickest route to the easiest hospital they can get to. So we'd have to look at how would that affect transfer patterns and delivery patterns, and would we, if there's a hospital right across the border, would it impact their ability to get there as fast as possible? Because remember, 15 minutes or less is the best. So I think that's an excellent question, and it would be nice to be able to research that and come up with an answer.
Well, and I guess where I'm going with that is, it seems to me like if we had the facilities in these areas, dark green areas,
So it's mouse run, not.
then maintain, if we were able to maintain, because I know that we couldn't go to Tennessee,
Right.
they could go to lots of hospitals up there that
Right.
10, 25 miles before.
Mm-hmm.
And that's money going out of state that's taxpayer money.
Good point.
It could stay in state and support hospitals that provide lots of other care.
Good point. Thank you.
Any final questions? Thank you, Pat.
Thank you.
Jimmy Lewis? Introduce yourself to the members, if you don't mind.
Yes, sir. Thank you, Mr. Chairman. Thank you, members of the committee. My name is Jimmy Lewis. I'm CEO of Hometown Health, and Hometown Health is a business association of rural hospitals. We have about 55 rural hospitals that we work with in Georgia and about 12 or 14 in Florida. Our purpose is to do whatever it takes operationally to try to keep a rural hospital open and going, so we're deeply involved in all of the strategies with respect to those hospitals all over the state of Georgia. I come to you today with a very simple message, and that is to say thank you to the governor and thank you to the budget as we have it pertaining to private dish funding. We have sought private dish funding now since the conversion from Medicaid over to the managed care operation several years ago. And because of some changes in definition, there were a group of hospitals that were declared by that definition private. And because they were private, they could not make IGTs, and because they could not make IGTs, intergovernmental transfers, they had to rely upon the state to come up with the dollars for that group of hospitals, and it's about 18 or 20 hospitals. The amount of money has been about $21 million. Typically, the state, by federal mandate, has to fund what are called deemed hospitals, and because of the way the Fed's rules are, that was automatically put in normally by OPB. And then the remainder, which was the non-deemed category, was usually about $10 million. And that had to be sought and worked through the process every year. And we have talked and educated people at OPB and in the governor's office as to what that really means. And having not had that approved up to this point in time meant that that population of hospitals had a high degree of uncertainty in their financial planning because they relied upon that dish and they couldn't get it. The governor and the OPB have sought to put that in the budget, and it's there, and we are very appreciative of it. And what that does is for that group of hospitals, it contributes to their certainty of operation through the first 6 months of this year. And for that, we say very much thank you and encourage you to continue to support that through the budget process, that it stays and recognizes the governor's willpower to make that happen. So that's my thank you. If I may, I have one point in support of Pat Cota. Because I represent the rural hospitals that we do, I want to say that her message is critical throughout the whole arena of rural hospitals. That we have had 34 critical access hospitals, and now I believe all of them but 2 no longer deliver babies. The next level up, called PPS, we've had some 12 to 14 of them to drop, as she indicated. And I can tell you that I just came out of the field, and 2015 will be a year in all probability that there will be further reductions in the number of delivery systems because of the payments, the compensation that goes with it. And the further part of that is that when a hospital loses its OB and it has to suffer the loss of that, there's a follow-on loss that goes with the family leaving, and the typical hospital who does OB versus non-OB, the non-OB hospital has 8% less volume because the parent carries that volume with them to another hospital. So this is a critical part of the system, and for the OBs that go away, the hospital is in quite much trouble soon thereafter. So I support very much what Pat had to say. So.
Thank you, Jimmy. Are there any questions from any members? All right, Rick Ward.
Thank you, Chairman Burke and Chairman Parrish, members of the committee. I'm Rick Ward. I'm the Executive Director of the Georgia chapter of the American Academy of Pediatrics. We're the professional medical association that represents pediatricians, both general pediatricians and pediatric specialists such as pediatric cardiologists, pediatric neurologists, and so forth. Today I'm pleased to have Dr. Bill Sexton, a past president of the chapter, to speak for us on this very important matter. If with the chairman's permission.
Welcome.
Good afternoon. Thank you very much. And before I start, actually, in response to the question earlier that was asked by Mr. Hawkins, the current cost, just to give you some idea of neonatal care, we generally will tell the, by the way, I do neonatology. I work primarily at Grady. And we're one of the biggest regional perinatal center in the state. So this is something I do on a daily basis. What we tell the parents is generally that the babies will go home about the time it would have been born. In obstetrics, we have many, many ways now that we can intervene if a mother goes into premature labor to get the pregnancy further along. So the baby is not born so prematurely, so that the quicker you can start those interventions, in general, the further along in pregnancy the baby can get, the more mature the baby is, and the fewer problems, and thus the less cost. So that using Pat Coda's data of about $4,500 to $5,000 a day, you can predict that for a baby that was born at 30 weeks of gestation, normal length of pregnancy is 40 weeks. You've got 10 weeks at somewhere around $5,000 a day for probably the first 2 to 3 weeks. And after that, it drops down to about $1,500 a day. So that doesn't give you an exact dollar amount, but it certainly tells you something about the magnitude of the cost. Certainly. First of all, thank you all very much. Just as I look at the paper and as I think about folks that have really tough jobs in today's economic climate, you all have really tough jobs. So I want to thank you for hearing what we have to say today. One of the things that I wanted to do primarily is to urge the House the Joint Appropriations Committee to add funds to both budgets, the supplemental as well as the budget you'll be hearing for 2016 later in the session, to increase Medicaid reimbursement rates for physicians back to Medicare levels. There are several, I think, critical factors on this, and you all have a handout that Rick has provided. But the first and I think the biggest point is that the state has not seen an increase, physicians have not seen an increase in the Medicaid budget, the reimbursement, since 2001. If you take a look on the reverse side of the page, you get an idea of the flow of the Medicaid budget over the course of the last couple of decades. And you can see that up until the mid-90s, Medicaid reimbursed at 100% of Medicare rates, and that beginning in 2003, 2004, there was no change at all in the reimbursement rate. So that currently, one of the things that's happening is that in terms of the Medicare budget, Medicaid is reimbursed at about 75% of the Medicare budget, so that anybody that takes kids, indigent folks, whether those are OB, primary care, family practice, or pediatricians, they're getting substantially less money and substantially less ability to maintain their practice, which I think really goes back to the point that was made earlier about what happens in rural Georgia. At this point, about 43.2% of all the kids in Georgia from newborn to 18 years old receive their health insurance through one of the various Medicaid programs. So that Medicaid is extraordinarily important to the health care of the kids. Now, I know from reading the paper that, that one of the pushes for our government this year in the state is to increase education. But I think that you have to remember that if we're going to have a well-educated group of kids, they also have to be well kids. Sick children, children that have been born prematurely that may have other problems are not going to be the kind of children that learn well. So that we need, in order to be effective with our education, we have to be effective with our health care as well. The other thing that I wanted to embellish on that was said by Ms. Cote earlier is that rural practices frequently have a heavier Medicaid load than do urban practices, and as a consequence of that, it really is imperative that you look at the reimbursement rates. As hospitals have closed in the rural areas, the physicians no longer have a way of supporting their practices if the reimbursement rates drop from 2013, 2014 levels back down to the previous Medicaid rates. And it really concerns me is that not only are the hospitals closing in the urban or in the rural areas, but that pediatric practices, primary care practices, OB practices may well have to close, as was previously said. I think the last point to make is that Georgia currently has a deficit of pediatricians in 23 counties, and in 61 counties, and there are 23 counties with no pediatricians at all. So while our situation is not quite as dire as the obstetrical situation, it certainly is very, very bleak in many of the rural counties for our children. Thank you again. Are there questions?
Thank you, Dr. Sexton. Let's see, there is a question.
I'm interested in the enhanced reimbursement for primary care physicians under the Affordable Care Act. Do we have any evidence whether or not that in fact attracted additional physicians to the Medicaid program?
Great question. Actually, I was on a conference call with some of our pediatricians and subspecialty pediatricians, and because of the bump that occurred over the course of the last couple of years, there were a number of the practices, particularly in South Georgia, and that were able to expand their practices into other counties in the surrounding area. And in fact, the Sibley, one of the docs from the Sibley Heart Center here in Atlanta had said that they had just developed a new clinic in Southwest Georgia that allowed kids from that area to actually be seen and not miss school, so they're not driving all the way from Albany up to Atlanta to have their heart checked. So yes, there has been very tangible evidence that's occurred.
So there are anecdotes, but is there any research data that will support that point of view and those?
Yeah, sure. Rick?
If I may, Representative Gardner, no. The answer is no, because it's too early. Remember, this was a 2-year payment increase for calendar 13 and 14. The money, because of various issues, many of them at CMS at the federal level, didn't even begin to roll into practices until early in the fourth quarter of 14. Plus, doctors knew that this could be temporary, and so they didn't make business decisions about broad expansions, et cetera. We do have anecdotal evidence, as Bill has pointed out, where we've heard people tell us that they have opened a second office or a satellite or done this or that, or perhaps expanded their Medicaid panel from 40% to 50 or 20 to 35 or something like that. But it's just too early to tell in terms of a particular study. But we certainly think it has helped.
Your association hasn't done any analysis of the impact. I guess that's really
well. There's no analysis to do just yet. We're in the process of surveying our members, by report, to ask them, did you expand, did you do anything differently in anticipation of this, or with these extra funds at Medicare rates, and we should have that in a week or two.
Great. Thank you. That's what I was interested in.
Any other questions? How about in the audience? Any questions?
Thank you all
Thank
very
you all for your
much.
presentation. Beth English is next.
Thank you, Mr. Chairman. My name is Beth English. I'm Executive Director of Easter Seals Southern Georgia, and I serve as the Coalition Chair for the 5 Easter Seals in Georgia. And I'm here for 2 reasons. One is to thank you for putting $250,000 in the FY15 budget that made us whole for this calendar year for the Champions for Children program. For those of you who were here in 2006, and there are some of you in this room, you'll remember that 1,600 children with disabilities or medically fragile were dropped from the Katie Beckett waiver. And as a result, the Georgia General Assembly put money in the state budget to provide services for these children. These are working families who have children with severe disabilities that do not qualify for any kind of government assistance. And so with that, the Community Foundation of Greater Atlanta issued vouchers for those families for a year, $2,600 per family, and also did focus groups across the state to find out what those families needed. As a result, the Champions for Children program was created, and Easter Seals Coalition was the effective contractor for that program through a competitive bid process. We were asked to serve 192 children. We were asked to implement statewide in 2008, and we were asked to make the funding go for 5 years. I provided you with the 2014 report, and you can see that we've more than doubled the number of children served. We've expanded the funding several years beyond what the original funding was intended to do. And we continue to try to expand the program as more and more children are being dropped off Katie Beckett. We provided some information to the Senate Research Office recently that shows children who have been on the Katie Beckett waiver for 10 and 15 years are now being dropped. And those are children that don't have a lot of other resources, their families. But anyway, I do want to thank you. I do want to let you know that we will be back at the 2016 FY budget hearing. But I wanted you to see where the funding went, how it was spent, and 100% of these dollars do go to support the families. And I'll be happy to answer any questions if there are any.
Thank you, Beth. Any questions? I don't see any.
Thank you.
Thank you. Steve Neff.
Good afternoon, Mr. Chairman, members of the committee. My name is Steve Neff. I represent the Georgia Association of Community Care Providers. We're about 350 or more home and community-based service providers that represent and take care of folks that fall within all of the waivers. So that could be within the CCSP waiver, within the developmental disability waiver, within the ICWP waiver, and so forth. I don't have a specific 15 item. I want to thank you all for some work that you all did out of both houses last year in the governor's office. Under the Community Care Services Program, the personal support waiver, which is home care, when someone comes in to take care of them in their take care of an elderly person in their home, received 5% rate increase, those providers. And then the alternative living services, which is assisted living, received a 5% rate increase. And then the ICWP waiver providers, thankful to you all, received, which is brain and spinal injury folks, received 5%, and we wanted to thank you all for those. The developmental disability waiver, which is called the Now and Comp, received a 1.5% rate increase waiver, in which we thank you all for very much. What point I wanted to bring with that with regards to 2015 is we've worked very closely with the Department of Community Health, because all of the other waivers, eventually those rate increases were moved forward and were implemented. Unfortunately, for the developmental disability waiver, it's taken longer to work through CMS, and it has not been implemented yet. I assure you we're working closely with DCH. I know that you all are as well, but I just wanted to bring that to your attention because we are hopeful that that would be implemented before, before we come back for 16. With regards to 16, since those waivers were so kindly to be able to have rate increases for those there are several within the CCSP program that were not able to receive rate increases. That could be things like adult day health, things like respite, home-delivered meals, emergency response services. Phone, I can't get up. They have also, just like the others, not received rate increases in 12, 15, 20 some odd years. So we would like to come back with you and talk with you in 16 about possibly bringing up the rest of those other groups up so that they could have rate increases and provide services for the elderly and disabled across the state. So if anybody have any questions for me?
Any questions? I don't see any on the panel. Any members in the audience?
Really appreciate the opportunity and look forward to coming back again in 2014 if y'all will have me.
Thank you for the presentation.
Thank you, sir.
Anyone else that's not signed up that has the desire to come forward?
For our members, House members on the subcommittee, Jesse has passed out some reading material for you. If you'll be sure and get that if he hadn't got it to you before you leave. And just remind you that we'll meet in the morning at 8 o'clock here in this room to hear from the departments.
Thank everybody for coming. We're adjourned.